Hello guys, so today we are going to learn about the infections and oncology from Farre. So this is about the most important topics from the orthopedics and frequently repeated questions which are going to be asked in your prof exams. Okay, are you all ready? So today we are going to deal about two more important topics, that is infections and oncology, as I have told earlier. So in infections we have two important infections, that is acute osteomyelitis and the chronic osteomyelitis, right? And then from the spine, the TB spine is supposed to be the most important question. And then we have our tumors, that is your osteosarcoma, your Ewing sarcoma, and the most important giant cell tumor. Okay, so that's it for today. So let us start with the first important topic, that is your osteomyelitis. So first, any exam, we are going to start with the definition, right? So we are going to write the definition of it. So you know this is osteomyelitis, that means this is an infection of the bone. So what do you mean by osteo? Osteo is bone, plus myelus is marrow, and itis is your inflammation, right? So whenever there is an bone and marrow inflammation, that is because of the infection, right? So that is of the infection. So this is called the osteomyelitis. And here what we are going to write, the definition has nothing but osteomyelitis is a condition which is caused by the infective organism, that is the microorganisms, which will result in the inflammation of the bone and marrow, right? So that is the definition. And then most importantly here, this is supposed to be one of the most common condition which is usually seen in case of children. Usually we see this in case of children. And what is the causative organism? So as I've told you that this is not a something which is inside the body, it is somewhere from the outside the body. So something is the some foreign organism is coming from outside to the body, which is resulting in the infections. So we have to write that most common organism which is involved is your staph aureus. So most common organism is your staph aureus, where it contributes up to 70% of the microorganisms, right? So most of the common microorganism which is responsible for the osteomyelitis, especially in the children, is your staph aureus. So staph aureus is about 70%, right? And then comes the another most important, that is your group B streptococcus. So group B streptococcus, right? So mostly it is agalactae. This is in case of your neonates. This is in case of your neonates. So you're going to write staph aureus first, then streptococcus. Then in case of IV drug abuses, in case of IV drug abuses, it is Pseudomonas aeruginosa. So Pseudomonas aeruginosa is one more important one, which is responsible for your infection in case of your IV drug abuses, right? Then we have one more important thing which you have to remember, that is in case of your sickle cell disease. So any person who is suffering from sickle cell anemia, so in this there is a particular organism which you have to remember, that is your Salmonella typhi, right? Salmonella typhi. So these are the most important things. You can name some of them like staph, strepto, Pseudomonas aeruginosa, Salmonella typhi, and sometimes it could be your E. coli. And not to forget about your H. influenzae. So this is also one of the important organism, but because of the vaccination which has been started from around in 2000, so this has been come down. So the occurrence of this organism has been come down, but before it was H. influenza also, and Proteus mirabilis also one of the organism which you have to remember. So these are the causative organisms. So first is the definition you're going to write, then you're writing the causative organisms. Then you're writing the pathology. So in the pathology, what you have to understand is what is the most common site where this infection is present. So we all know this is the infection of bone and marrow. So in the bone, where is the most common site? And that is the most favorite site for the organism. So what is that most common site? So that is your metaphysis. So metaphysis of the bone is supposed to be the most common favorite site for the organisms to thrive, to multiply, to propagate. So this multiplication of the organism, is occurring in a particular area which is called the metaphysis. And why the organism has specifically chosen this metaphysis is because of the orientation, because of the arrangement of the blood vessel pattern, that you have to remember. So the blood vessels are arranged in a hairpin loop. So hairpin loop arrangement of the blood vessel. So this is the metaphysis area, and you can see this is the metaphysis, right? And you see this is the artery and this is the vein. So when they're connected, they are forming a loop. So this is the loop, right? So this is the loop. So this is the loop. And if you remember, whenever we are traveling on the road, so you want to take a U-turn, what do? You just come fast on the straight road and you slow down and then take a turn, right? So this is a natural tendency where whenever there is a loop, whenever there is a turn, we slow down. So the sluggish blood flow also, the blood flow also slows down here. And now this blood, whatever is present in this particular area, will act as a culture for the bacteria to grow. So this is one important arrangement, that is a hairpin bend or hairpin loop arrangement where the organisms thrive in the metaphysis. And the second one is there is a decreased macrophages in this particular area. And the third one, they constitute to tell that the oxygen tension is also low here, and hence it again forms a very good area or the site for thriving of that bacteria. So these are important things which you can remember. So this decreased macrophages is nothing but the defense mechanism is low here. So the defense is low, right? So hairpin loop arrangement, decrease so the main reason for hairpin is sluggish blood flow. So if you want to write the reason behind it, is the sluggish blood flow. So hairpin arrangement which results in the sluggish blood flow. So the organisms can thrive because they're not pushed like that. So they have some time and space to perpetuate. And then because of decreased defense system and the oxygen tensions are also low in that particular area, hence the metaphysis is supposed to be the most common site and the most favorite site for the organisms. And particularly in case of knee, so it is the tibia where usually they usually are present. See, the organisms are present in the metaphysis. But when it comes to the hip joint, sometimes what happens is this metaphysis, this area, this sometimes is also connected with the epiphysis in case of neonates. So in such conditions there is also a possibility that it spreads to the joint. So there is also a possibility that it spreads to the joint. Like for example, if you take the hip joint, so what I'm trying to tell you is the epiphysis, then the physis is inside the capsule and then forms the metaphysis. So what happens is, because of this connection between the epi and the metaphysis, and sometimes the vessels, so if this is the epiphysis, sometimes the vessels are also connected. So there is some connection with the metaphyseal vessels and the epiphyseal vessels. So whenever the metaphysis and epiphysis is connected, especially in the hip joint, so metaphysis is connected with the epiphysis, so always there is a probability of the joint to get infected. So always there is a probability of the joint to get infected. Right, so because this epiphysis is enclosed in a capsule, so there is a chance of it spread from metaphysis to the epiphysis, right? So this is how the hip joint is affected. And in the neonates, usually this is seen as the septic arthritis. So this is the one important point which you have to remember whenever we are talking about the site, right? So that is one thing. So once the organism gets lodged there, so once the organism gets lodged, so it has found its favorite spot, that is the metaphysis. And usually the spread is through the hematogenous, so hematogenous spread. So you have to remember that this is through the blood, the organisms enters the bone, and there it thrives, multiplicates, and then what does it do? So once the organism is multiplying, what happens is, in the metaphysis it forms small thrombus, right? And then this will result in formation of edema. So this edema will increase the pressure, so increase in the pressure of the bone. So the bone intraosseous pressure rises. So whenever there is again rises pressure, so there is again a decrease in the blood flow, right? Again the decrease in the blood flow. So that is how the organism multiplies. And now because of this increase in the pressure, and there is an accumulation of accumulation of all the neutrophils, and now they try to encounter with the bacteria, and this will result in what is called as the pus or the abscess. So this will form a pus or the bone abscess. So this is how the acute osteomyelitis is there. I'm just searching for the diagram. So this is the diagram. So now I have explained you. So this is the growth plate, right? And see, these are some of the vessels which are going into epiphysis. So such vessels whenever are present, this might also result in the epiphyseal infection and from there to the joint. And here if you see, this is the infection. So in the metaphysis there is a small foci of the bacteria that is getting multiplied, and whenever the defense mechanism fight with it, this will result in a form of a pus. So this pus will be present under the periosteum, because the periosteum in the children are very, very thin, right? So the periosteum is very thin, attached to the bone. So itself, the periosteum itself is thick, but the attachment to the bone is a thin layer. Okay, very thinly attached to the bone. So this will get elevated, resulting in formation of what? Subperiosteal abscess. So there will result in formation of your subperiosteal abscess, right? So what are you going to write in the pathology? So if you forget all this, what are you going to write? In an order you're going to write. So the first organisms you're going to write, then this hairpin loop you're going to write, and then the organism enters, and this will result in the form of thrombosis of the vessels, right? And it will result in the form of edema, which will raise the pressure, and this will result in bone necrosis, right? So bone will get dead whenever there is rise in pressure because of the decreased blood supply, and bone is very susceptible to then the soft tissue infection, right? This is one of the important points. So bone is very, very susceptible, very, very sensitive, right? And now what happens is, as there is this process which is happening, raised pressure and bone necrosis, now what the body will do? The body will respond and will fight with the bacteria, right? And this will result in the formation of pus. So what is actually pus? Pus is nothing but your leukocytes, your tissue debris, right? And your bacteria which is dead. So all this will result in the formation of pus. And I told you this periosteum is faintly attached. So this pus will form the subperiosteal abscess. So this will form your subperiosteal abscess, right? And now this is the time where whenever there is an abscess, so this is the inflammation. So now the body produces swelling, pain, tenderness, fever, rise in WBC, rise in ESR. So these are all the signs and symptoms. So these are nothing but your clinical signs and symptoms which have been produced. So the patient will come with swelling, a mild swelling, then there will be pain and tenderness, and because it is almost metaphysis is near to joint, sometimes there will be restriction of the movements or painful movements, or the patient will not allow you to touch, right? So this is what happening, and the patient will come to you at this stage where there is pain, swelling, tenderness and fever. So now you do some of the tests where you see there is a raised WBC and raised ESR, right? And at this point, if you intervene with the antibiotics, so when you intervene with the antibiotics, right? So before that, how do you manage this case? So before that, what you have to do, you have to always examine, and there is tenderness, labs, there is WBC raised and ESR raised, and as the prediction, we have to go for the X-ray as well, right? So but what happens in the X-ray? X-rays are usually normal. X-rays are usually normal up to 2 weeks. Up to 2 weeks, the X-rays are normal, and still you're not going to wait for the X-rays. What you're going to do after 2 weeks is there is a periosteal newborn formation, right? So first we have come up to the place where there is rice fever, WBC and RBC that I have told you, right? And now we are going to take the x-ray, but x-ray appears to be normal. Only after 2 weeks you will see there would be a periosteal newborn formation, and still if the infection persists at the metaphysis, you can see haziness or the rare fraction, but before that you're going to intervene. You're going to always intervene at the presence of fever, and with your lab you're going to confirm the presence of the infection, right? And you can also send it for the culture and sensitivity. And then what is the treatment? So treatment is always empirical antibiotics, right? The empirical antibiotics. So here you should always start the antibiotics before the x-ray newborn formation, before the culture sensitivity reports have come. So how do you going to start the antibiotics? So usually what we do whenever it is neonates or up to 6 months of age, usually we know it is the staph aureus, right? So flucloxacillin plus third generation cephalosporin is given, or one more combination, these two plus you can also add gentamicin, right? So this is the treatment for a neonate plus up to 6 months, right? So this is the treatment for neonate plus where we have to give this is penicillin, benzyl penicillin, flucloxacillin plus third generation cephalosporin. That could be a taxim, that is cefotaxim, and then you're going to add the gentamicin also. Okay, and if the baby is more than like 6 months to 2 years, because it is sometimes Haemophilus influenzae, if the baby has not taken any vaccine, you can add with your fluoroquinolones, that is your ciprofloxacin, right? So always remember this is in addition with your flucloxacillin and your third generation cephalosporins. So always these two are very, very important. So third generation cephalosporins plus you're going to add based upon that antibiotic, right? Even if it is Salmonella typhi, it is again your ciprofloxacin, right? And then if it is your MRSA, so staph methicillin resistant MRSA, then you're going to go for injectables, that is vancomycin. So you're going to vancomycin. Okay, so remember these are some of the antibiotics which you have to remember empirically, and again depending upon the culture and sensitivity you're going to change the antibiotics. So fluoxetine is one of the most important for staph aureus, and then your third generation cephalosporins will do really well. And whenever you are in doubt, you can still add a gentamicin for it, or if it is Salmonella typhi you're going for ciprofloxacin, or if it is MRSA you're going for your injection vancomycin, right? So then what is the surgical treatment? So surgery, whenever it comes to surgery, you have to still wait and see for the response with the antibiotics, and still you have any doubt of pus formation, this has to be removed. So pus formation has to be removed. So what we do, we drill holes in the bone so that the pus will completely drain. So if this is your bone, so you're going to drill the holes here. So these are the holes which we are going to put, and these holes will remove the pus. So if there is a large amount of pus, you're not going to put multiple holes, but what you're going to do is put a small window here. So with the help of the osteotome, you create a small window in the cortex, and you open the window and leave the window open for the pus to drain, right? So this is the surgical thing which we do. And after that, post operative care, you have to always give splints and continue antibiotics at least for 6 weeks. So 6 weeks, 2 weeks we're going to give injectable form, and 4 weeks we'll give oral form, right? And this is how you're going to treat this. And you have to always remember that the complications, so the complications of acute osteomyelitis is the first thing. Whenever it is not treated well, it will result in your chronic osteomyelitis. So it will result in a chronic osteomyelitis, and sometimes it may land up with septicemia. So the bacteria will spread hematogenously to multiple forms in the body, and it will result in your septicemia. So this is most important one is chronic osteomyelitis, and second one is your septicemia. So you have to be very, very careful, and sometimes it might infect the joint also and will result in your septic arthritis. So it goes to the joint and it results in your septic arthritis. Okay, and if the joint or physis is involved, it might result in the deformity, right? So these are all the various complications of your acute osteomyelitis. Okay, so talking with the one important complication, that is your chronic osteomyelitis. So I told you, if the infection is not treated well, right? So whenever the infection has to happen in the body, the host response has to be low, right? So the defense mechanism, the host has to become susceptible for the infection, or the infection virulence should be very high that the host cannot compete with it. So that is when we'll end up in infection, right? But what about chronic infection? In case of chronic infection, what happens is the host resistance, as I have discussed, becomes very low, or this virulence of the organism is high. So whenever there is high virulent and resistance is low, but when the treatment of acute osteomyelitis is inadequate or neglected. So one of the most important thing is neglecting of the treatment, and sometimes the implants, the presence of the implants. So all this will result in a chronic infection. So this will result in a chronic infection, and in the chronic infection you have to remember that there are active phases and there are quiescent phases, right? So active phases and quiescent means silent phase, where there is nothing with the patient. So patient feels that he has become normal, but again it become normal, but after some time, after like 2 or 3 months, after 6 months, again the infection flares up. That could, the reason could be because the immunity again has gone low, or there could be some trigger of the infection again. So infection has been present in the body only to reoccur after some time. So there are active phases and the quiescent phases, that is a silent phase. So how do you identify such people? So these people, they present with multiple sinuses. So they present with multiple sinuses, and these can be present and seen as scars. So scars and puckering of the skin becomes thick, thickened, puckered skins, which can be seen whenever you deal with people with chronic osteomyelitis. So what actually happens in the chronic osteomyelitis? This is again the same pathology you have to remember. So again the metaphysis is infected, again there is a bacteria which is proliferating in the metaphysis, and the pus has been formed. This pus forms its way in multiple ways. So it can go subperiosteum and deposit here, or sometimes it goes again and infect one more bone here. So in this chronic osteomyelitis, what happens, as I've told you, there is a necrosis and there is a thrombus formation, right? Starting with the thrombus formation, there is a edema which is present, and then there is raised intraosseous pressure, right? So whenever there is raised intraosseous pressure, the blood supply will get decreased, and now this bone will become necrosed. So there is a part of the bone which is completely devoid of the blood supply, and it completely become dead, and this dead bone is surrounded by a granulation tissue, because the body constantly reacts for the foreign bodies. Like now the dead bone is the nidus, and now the body reacts to it and forms a granulation tissue around it. And now the normal bone which is present, the viable bone, it gets stimulated because of this granulation tissue, and it forms a new bone which is called as the involucrum. So this is what is happening in the chronic osteomyelitis. So first, the nidus is nothing but, or the necrosed bone. So nidus is nothing but the necrosed bone. Now this dead and devitalized bone, this is called as your sequestrum. So this is called as your sequestrum, right? And this sequestrum is surrounded by the granulation tissue. So this is surrounded by the granulation tissue, right? So this is unhealthy granulation tissue. And now this stimulates the normal bone, and this normal bone again is formed outside the granulation tissue. This is called as the involucrum. This is called as the involucrum. So there are three parts. So one is the sequestrum, then you have the infected granulation tissue and the bone, which is called the involucrum, right? So these are the parts. And now if you see this dead bone, which is acting as a nidus, I told you this is acting as a nidus. Nidus means it is the resident of the bacteria. So this is the residence, home of the bacteria. So the bacteria nicely sits, make friends with this dead sequestrum, and they both happily live there, right? But we don't want something dead and something which is not helping our body to be inside, right? So we want it to go out. But what does it do? It forms pus. So a lot of reactions which is happening. So it forms pus, it forms spicules, and now through the periosteum. So through the periosteum or through the new bone, because of the raised pressure, the pus or the bone is pushed outside, and this pushing can come towards the skin. It breaks the skin and present on the skin as a sinus tract, right? So there are multiple sinus tract, and this is coming to the skin. So this is sinus tract on the skin, right? And this opening on the normal bone, so there should be some opening for the sequestrum to come out, right? So this opening is called as the cloaca. So these are certain words which you have to put in the exam. So you're going to write or draw this particular diagram. Just draw a bone like this and name this as the metaphysis. So this is your physis and this is the metaphysis. And here you see some dead bone surrounded by the granulation tissue. And then you have the normal bone, right? Everything else is normal here, right? And this normal bone, this dead bone will form a lot of pus, and this pus will come onto the skin. So remember, there should be some evidence of the skin, and this particular pus will find its way and will present as the sinus. So now this is your sinus tract. So this is your sinus tract and this is your sinus, and here the discharge is what? So discharge is your bony spicule. This is not something or this is not some fluid, right? So the discharge here is bone itself. So white spicules has been discharged, and this presence of white spicules as the discharge is itself pathognomic for diagnosis of chronic osteomyelitis, right? So this is what you have to you're going to write and draw this particular diagram and name accordingly. Okay, so that is the pathology and the pathogenesis. So once this bony spicules is come, the patient will come what? Will come with, again, there would be pain, there would be deformity. I told you the skin here is very important. You have to check the skin. The skin is with presence of multiple sinus, with the scars, with the puckering thickened skin, and with discharging bony spicules. So there will be discharge of multiple bony spicules, right? So this is called the sequestrum, right? And this is the chronic osteomyelitis. So once you're done with the pathology, then again clinical signs and symptoms, you go for the x-ray, right? So here the x-ray, what you see, you already know the pathology. So x-ray, what are you expecting to see? You will see the bone, right? So bone is not normal, so there is some differentiation of the cortex and the medulla. So first what you see is the haziness. So the bone is not as usual, so you can't see good medulla, good cortex. It is not seen, everything is mixed. That is called the haziness. And the most important thing what you see on the x-ray is this. So this is the sequestrum. So what is a sequestrum? So you see sequestrum on the x-ray. So what is the sequestrum called? It is called the dead devitalized bone, right? So this is a dead devitalized bone with increased density, because something which is dead, there is no blood supply, so there is no normal process of osteoporosis. So what usually happens, the bone is a dynamic thing, right? So there is a blood supply and usually there is a resorption. So the bone formation and resorption. Why there is a increased density? Because there is decreased resorption. So always the bone has to look normal. So that is why there is a resorption which is happening, But here, because it is a dead and the devitalized tissue, there is no blood supply, right? So that is why it appears to be increase in density, so it appears more white in color, but what you have to remember, it is surrounded by lucency, so this lucency is nothing but your granulation tissue, right? Clear? So that is how you read the X-ray, and you find next to it is a thickened new bone. So this bone which is formed is thickened, and this new bone, again we know it is called the involucrum, and you can see some openings on the involucrum which are called as the cloaca, right? And sometimes the patient can also present with the pathological fractures. So they can also present with the pathological fractures on the X-ray. So you have to always look for the pathological fractures as well on the X-ray. And sometimes this, in case of spine, if we are dealing with spine, you have to look for the abscesses. So usually in the pyogenic, like in case of bacterial infections, the pus is not actually seen on the X-ray. These are present as spicules. But in case of spine, these are seen as abscesses, right? So X-ray, you have to remember that. Okay. So now this is the X-ray. What I have told you is this is the sequestrum, the dead and devitalized tissue with increase in the bone density, which is surrounded by lucency. So this is the sequestrum, and this thickened bone is called your involucrum, and this is the haziness what I told you, which you can see in the metaphysis, right? So this is about the X-ray. And then after the X-ray, you can always go for MRI, and you should always go for culture and sensitivity and your lab. So there will be raised WBC, again there would be raised ESR and CRP, but only in the active phases sometimes, but sometimes they may be mildly elevated in the silent phase also. So this is how you come for the diagnosis, and sometimes you can go for sinus tract, right? So you can identify the sinus tract with the dye. So you can identify the sinus tract, you will inject a dye into the sinus tract, and you can trace the sinus tract also, right? Then coming to the management. So how do you manage this case or treatment, right? So management is nothing but it starts right from the diagnosis and the treatment. So diagnosis part we have discussed. So now the treatment part. So treatment, what you have to do, you know what is the nidus, you know where the infection is coming from. So you have to remove the sequestrum. So removal of the sequestrum is the treatment. Remove the sequestrum. And second space, dealing with the dead space. So once you remove the sequestrum, there is a dead space. So how do you deal the dead space? So the dead space, you can either put a cancellous bone graft, right? Or you can put antibiotic beads. So now let us discuss about how are we going to deal with this sequestrum. So first part, removal, is now you open, then remove the sequestrum. That is done. And now you see this removal, after removing, you will find a cavity which is something like this. So this is the cavity. So now we are going to deal with this cavity. How we are going to deal? That is called as saucerization. So you're going to open the cavity, curate it completely, and break the walls. So whenever you break the walls, this will become a saucer-like thing, which is called as saucerization. Sorry for the spelling. It is called as the saucerization, right? So this is called the saucerization, right? And why we are dealing with saucerization? So whenever there is a formation of pus like this, because there is a cavity, it sits in the cavity and there is no space for it to come out. So when you do this, because this is a very narrow thing, and you can see the in saucer, when you put the fluid, it floats, like, so with that float it will drain, so there is no space for the bacteria to multiply. And now the second thing how you deal with this, the dead space, is I told you that first you are going to put some bone chips. So for example, if this is your cavity, you put multiple autologous, that is bone chips. You remove bone, and this bone chips are mixed with antibiotic and you present there. And the second one is you prepare the cement with antibiotic, and this will form into beads. So you take a small K wire and then you put all these beads to this K wire, something like this, and this beads is put in this cavity. So everything, these two are filled with antibiotics. So these are filled with antibiotics. So you will put these antibiotics with the help of cement, that are beads, or with the help of bone. Okay, bone graft we take, make it into small pieces, mix it with cement, and then put it. We take cement, that is bone cement, mixed with antibiotic, make it into small beads, put to a K wire, and we make it like a string of necklace something, and then we put it in the cavity. So both these are techniques which are, used for filling the dead space. And sometimes we can do the irrigation. So this is called as the continuous irrigation. So we do continuous irrigation. So we run the fluid continuously with the antibiotic again, so that the cavity will be devoid of the infection, and it will help to formation the granulation tissue. So this is the treatment of the chronic osteomyelitis. All this is done under the blanket cover of your antibiotics. So antibiotics are very, very important. So whenever you're dealing with it, you have to always do under the coverage of the antibiotics, at least for 6 weeks, right? At least for 6 weeks. And then if the infection is still not controlled, always keep in mind, whenever there is an implant which is present, always it should be followed by the implant removal. So this implant will again act as a nidus and will not allow the bacteria to reach the bone. I mean, will not allow the antibiotic to reach the bone. So this implant will act as a nidus for the bacteria. So it will also resist the antibiotic penetrance. So first thing we have to do is remove the implant. So whenever the implant is infected, bone is infected with the implant present inside, so the first thing you do is remove the implant. And finally, if nothing is working and if you have some non-union of the bone, so the bone is not united, always aim for union, because the gaps are also again nidus for the bacteria. So aim for union, and this you can do with the Ewing fixation. So you can also use a technique which is called as a ring Ewing fixation, external fixation. So nothing is inside. So whenever there is an infection, we don't put any implants. No foreign body should be present inside, because even that foreign body will act as a nidus. So what we are going to do, we are going to fix the bone from outside through the Ewing fixation. So that is how we treat with the chronic osteomyelitis. So this is all you are going to write. So the first thing what you're going to write is the definition again. What is chronic osteomyelitis? When it occurs, so if it is untreatable or there is some mismatch in the defense and the bacteria, right? And then this is the chronic osteomyelitis, and it is in phases of, silent phase, active phase. And usually we identify this with the help of multiple bony spicules. Those are called the sinuses, which are seen on the skin, right? And this is all the pathology what we have discussed. And then you are going to write the X-ray, the MRI, which is very, very important, and then the treatment, right? So this is your chronic osteomyelitis. Then coming with the TB spine. So once we are done with the limb, so we are going with another bacteria, very, very important bacteria, and this has been our enemy, which is making us spend a lot of money for its research. So that important bacteria is Mycobacterium tuberculosis, which is very, very common in a country like us, right? So in India, whenever you want to diagnose something, which is not so typical and you're in doubt, always try with TB. Okay, so TB is one such infection which can infect anything in the body. And when it comes to our bone or musculoskeletal tissue, it starts right with bone, and soft tissue infections like as bursitis. So right from the bone, anything it can infect. So bone, it is wherever the blood flows, the TB flows. That's the myth. That is the fact. So wherever the blood flow, the TB can go and infect. Right. So always be careful with the diagnosis of the Mycobacterium tuberculosis. Right. So this is a rod-shaped bacteria, and usually what happens, the spread of this is through the spread of this is through hematogenous spread. So hematogenous spread is the blood, right? So where it flows, there are Batson's plexus of veins. So this word you have to remember. So it is nothing but your Batson's plexus of veins which connect the lung with your spine. right? So this connection of the lung with spine will result in flow of the bacteria from the lung, which is called the primary complex. If you go and read your second year pathology, we all know that the TB first resides in the lung, which is called as the Gons complex or the primary complex, right? So from here it goes to the spine through the plexus of veins, which are named as the Batson's plexus. So here you have to always be very, very careful. The classification, right? And you know what is this? What is this called? This is a normal spine, and this is called a spinal segment. So why this is called a spinal segment? Because the formation or the evolution of the vertebra is through a single sclerotome, which is like this. So here the blood supply is in this particular fashion, where the single blood supply will supply the lower end of the vertebrae of the upper and the upper end of the vertebrae of the lower. So this is called your upper vertebrae and the lower vertebrae, and the inferior part of the upper vertebrae, superior part of the lower vertebrae, along with the intervertebral disc. This particular point, this is very, very important to understand tuberculosis. So this particular point is the spinal segment. So always, that is why the most common presentation of the TB spine is paradiscal. That means paradiscal is around the disc. That is what, no, this is what I've told you. So this is the disc and this is the blood supply. So if the TB comes in like this, so it is always like this. The spread is always like this. This is called the paradiscal presentation. That's the most common type. Then what are the other types? So this is the paradiscal, what I was talking about. So this is the paradiscal or in and around the disc, and this is your anterior type. This is your posterior type. So if you remember, the anterior type is this. So where the spread of on the anterior aspect of the vertebral body. So this is the anterior type, and this is the posterior. So posterior, these are the posterior elements, right? It starts from the spinous process. So this is your spinous process. These are the transverse process. This is a pedicle here. So this pedicle, from the pedicle, like this is the posterior aspect. So this is the anterior, this is the posterior, and now this comes the central. So central is nothing but here in the center of the body. So body of the vertebra, and it is in the center. So that is your central. So this is the classification which you have to remember. So anterior, posterior, central, or vertebral it is called, and then we have the paradiscal. So this is the classification, and this is the pathology, how this is spreading. So as you all know, again the bacteria sits in, and it does the same thing. It does the same thing as it creates the inflammation, and then you have the formation of the pus, as I've told you. This is called as the abscess, and this abscess is specifically in TB, it is called as the cold abscess. Why it is called as the cold abscess? Because it doesn't present with any features of your Ruber, Calla, dollar, and tumor. So there is no classical signs of inflammation. There is no redness, warmth, and all that. How does it present? It just presents as a slight swelling, right? Depending upon the presentation. If it is lumbar, it presents as psoas abscess. If it is a mediastinum, that is thoracic, it presents as mediastinal abscess. So that is how it presents. So it is a lumbar, the psoas abscess or the mediastinal abscess. It presents in that way, and this is called as the cold abscess. That is what you have to remember. And how the patient presents. The patient presents with pain, that is back pain, and then he has difficulty in sleeping in supine position, which is called as night cries, and then he has the loss of weight, loss of appetite. So these are some of the symptoms which you have to remember, and more importantly, the low grade fever. So they present with low grade fever usually in the evening, which is called as the evening rise of temperature. So there are the evening rise of temperature with low grade fever, pain which is constantly present, dull backache pain with especially which has been aggravated in the night because of the relaxation of the muscle. So all the day along, the muscle gets contracted, holding the spine properly in the position. Once the patient relaxes, the muscle relaxes, hence the vertebrae is disturbed, the patient will end up in pain. Right? So then we have loss of weight and loss of appetite. So these are the symptoms and signs where the patient presents with. And now we go for the diagnosis of the case. So you thoroughly examine the case, and now you go for the diagnosis. The first thing what you do is order an x-ray, right? So the patient will present with an x-ray, and you can see that this is a typical presentation. The most common where it presents is the dorsal vertebrae, right? So the dorsal vertebrae and especially the DL spine, the dorsolumbar area, is the most common where the TB is present. And now you can see the vertebrae is deformed, right? Because there is lot of bone destruction which is happening, so the vertebrae is deformed here. So this is the dorsal vertebrae where it is involved, and now you can see formation of the pus which can be present as the bird nest appearance. So if the pus which is present will uh, will uh, uh, will go through on the anterior aspect or the posterior side, right? It finds its way, the least resistance pathway it follows, and then it will present as a bird nest appearance on the x-rays, on the chest x-rays, especially the lateral views. And then the most interesting feature is the MRI. So you have to always go for the MRI in case of the TB spine. So here the patient now comes with loss of appetite, I've told you, and pain, and sometimes they come with deformity. So this deformity is the destruction of the vertebrae, which will present as the gibbous or knuckle or kyphosis. So this is the deformity where usually they present with. So I have told you here the pathology. So there is an inflammation which is happening, and this inflammation will result in the bone to be result in the fibrous ankylosis. Okay, so there is a deformity which happening because of the inflammation, because of the infection of the vertebrae. The body gets this reaction which is called as fibrous ankylosis, and this will result in the deformity. So whenever there is only one vertebrae which is called as knuckle, more than two it is called gibbous. If it is more than three, it is kyphosis. Okay, so this is the deformity where they usually present, and this is what you can identify it on this image. So the patient is present with slight kyphosis here on the thoracic area. And now you go for an MRI, you see there is a absolute destruction of the vertebrae around the disc, which is again a feature of your TB spine. And you can see a lot of pus formation also here. So there is a lot of pus which is traveling here. So there is a pus formation that is called the abscess. So the pus here is called the abscess, and you can see the IV, the intervertebral disc, is completely collapsed. So there is no intervertebral disc which is present, and the bone destruction is very high. So TB usually result in this destruction of the vertebrae. So the bone is destroyed along with the disc, and it is usually above and below the disc. That is the paradiscal type, right? So that is the MRI of the TB spine. This is the X-ray of the TB spine, where you see again the deformed vertebrae. There is a reduce in the height of the vertebrae. So this is the reduce in the height of the vertebrae, right? And sometimes you can see the pus, it is following like this. So this is the bird nest appearance on the APV we see. So this pus will be present here, and this is present here. So it will appear as a bird nest abscess. Okay. And now coming to the treatment. So once we are done with the diagnosis, yes, you have to always go for culture and sensitivity, right? So here in the TB, you don't go for culture and sensitivity. Instead, you go for biopsy. And on the biopsy, what do you see? You see the giant cells here, right? Which are surrounded by the lymphocytes. And then we have various tests which we can done. That is your gene expert and CBNAT. So your gene expert and CBNAT are the two things which you send for biopsy, where you identify the tuberculous bacteria, right? So gene expert and CBNAT is very, very important, and there will be raised ESR. So ESR are usually raised, And sometimes you can see lymphocytosis. So the WBC is also raised, and especially the lymphocytes are supposed to be raised. So this is the signs, symptoms, and the diagnosis, how you result. And coming to the management. So management is again depending upon the stage of the tuberculosis. So sometimes the patient may land up with paralysis, so you have to be very, very careful. The treatment is again differs if the paralysis is, with red flag signs. So usually what we do in TB is we treat it with the conservative treatment. So treatment is conservative treatment where you rest, that is you give splint with the, what is that? Taylor's brace. So you give rest with the Taylor's brace, right? And then always under the cover of anti-tuberculous drugs. So ATT, rest, and splint, that is with immobilization. Usually the treatment of the TB is done, right? And this ATT is different, where you go for 9 to 18 months of the treatment, where you have two phases, that is the starting phase, that is and next is the maintenance phase, right? So you have the initial intensive phase, which is called the intensive phase, and the maintenance phase, right? So in the intensive phase, what you do, you take the help of the isoniazid and rifampicin, and sometimes you can add a fluoroquinolone also, right? And the intensive phase, you go with your ethambutol, combination of isoniazid and ethambutol, and then with your pyrazinamide, right? So this is about 1500, this is about 1200, I think. So this is the treatment. So we are going with the isoniazid, rifampicin, and fluoroquinolones in the intensive phase, where it starts up for 4 to 6 months, right? And this is up to 9 to 18 months you have to go, right? So this is the treatment. And now whenever you have a abscess which is present, so you have to always go for debridement. So usually what we do is we debride the case, we send the biopsy for testing, and then after that we start the ATT. But here, if you're still very confident about the diagnosis, you can directly start with the ATT, that is anti-tuberculous therapy, which has two phases, intensive phase and the maintenance phase. Intensive, it is isoniazid, rifampicin, and a fluoroquinolone, and maintenance phase you have ethambutol with pyrazinamide. Okay, and then you give complete rest. You're asking the patient not to do any type of activity, at least for first 2 months, right? And then the treatment would again be debridement, where there is a lot of pus, where you have a lot of tissue which used to be removed. Then we debride it, and then we can give a fixation to it, right? We can always fix the spine, removing the vertebrae, right? So you're going to do pedicle screw fixation with removal of the vertebrae, right? Sometimes for the decompression, you're going to remove the vertebrae along with the ribs, so which is called as the costotransversectomy. So costotransversectomy is the procedure which is done for decompression. So debridement is removing all the dead and tissue. So if the pus is very large, you have to remove a lot of pus, so you're going to decompress it. So decompressing is, you can go for simple decompression, only removing the part of the vertebrae, or you can go for costotransversectomy. So what is costotransversectomy? You are going to remove the rib along with the vertebrae. Costotransversectomy. So this is about the treatment of the your TB spine. But what I want to mention here is, sometimes whenever the treatment is not so proper, this might lined with the paralysis. So that you have to be very, very careful. So you have to look for the signs where there is an, bowel and bladder is involved, or sudden weakness, right? And sudden elevation of ESR. So all these are red flag signs. You have to always be careful about that. So involvement of bowel and bladder, increased weakness, or sudden weakness, sudden onset of weakness, or progressive weakness, all this will result in again the surgical treatment. That is radical treatment of removal of that particular decompression, what you are going to do. But otherwise, usually we go with the conservative treatment for the tuberculosis, right? So that is about your tuberculosis. So that completes the infection. So infection and your TB spine. Then comes with the oncology. So here in the oncology, what we are going to read is about your giant cell tumor. So we are going to read about the giant cell tumor. So this is also a very, very important topic and a very easy topic. I think you have been revising it multiple times. So giant cell tumor is, first thing what you have to understand about this is an aggressive, but it is a benign tumor. So one thing which you can be happy about it is still it is benign tumor, but this is supposed to be one of the most common tumor. So you usually we seen after the fusion of the physis, that is after maturity of the bones, never before the closure of the physis. So after maturity, so it is always in 20 to 30 years of age, right? 20 to 30, that is second decade. And this is a very aggressive tumor. I've told you benign tumor, you're happy that it's benign, but still their aggressive nature, you're not very happy. Why it is called aggressive? Aggressive in nature of its recurrence. So you have to always be careful and always counsel the patient that there is always a chance of recurrence, right? And you know what is the origin of the cell? As we all know, it is the osteoclast, and this is nothing but your osteoclastoma. So the one more name for it is osteoclastoma. Oma is tumor, though there is multiple cells which are aggregated to form a tumor, so hence it is called as osteoclastoma, right? And now this is called the cell of origin. So because of its association, so you already know osteoclast is associated with resorption. Resorption is nothing but lysis, right? And here I want to add one important or interesting point which will fetch you more marks. That is, this osteoclast is associated with the rank and rankel. So what is rank and rankel? Rankel is the ligand, rank is the receptor. So whenever these two are associated, this will result in resorption. This will result in resorption, as we have discussed. But nowadays, research has been proved that the denosumab is the drug. Denosumab is the drug which can inhibit, which can in what do you do, which can cut down the relationship between the rank and rankel and prevent the resorption. So giant cell tumor, this denosumab is been used before anything, that is before surgery, before curettage. You can put the patient on denosumab high dose, so that is 60 and 120. So we go for 120 mg denosumab so that the size of the tumor is decreased. So there have been researchers which have been said that you can start the patient with denosumab. So this is one interesting point which you can add as a recent advancement in the giant cell tumor. Okay, so now coming back to our regular things. Okay, so this is the aggressive bone tumor, most common tumor, but only after maturity. So it is usually seen in the second decade, and it is the osteoclast, the cell of the origin. So this osteoclast is also called as the giant cell, right? So how do you see? So giant cells are seen here. So this is called the giant cell tumor and the osteoclastoma, and we have discussed about the denosumab. And in continuation, I have told you this osteoclast is mainly responsible for a lot of resorption, so lysis. So here what happens is the patient comes with the symptoms of pain, right? Swelling, right? So here before that, what is the most common site? So this you have to remember. So the most common site is your knee, right? And then your radius or the wrist. So in the wrist, it is either the femur or the tibia, but most common again it is the femur. So right. So the knee is the most common site, and where exactly in the bone? So here this is becomes interesting, where you know that this is the epiphysis. So this is the tumor of epiphysis. This is very, very important. And whenever we write the word epiphysis, we can also include other e's. That is, it is an eccentric tumor, it is in the epiphyseal, and it is an expansile. It is an expansile tumor. So what do you mean by all three words? So epiphysis, you know, this is a place of the bone, right? We have epiphysis, metaphysis, diaphysis. So metaphysis, we know the infection is very common, right? And in the epiphysis, what are we understanding here is that giant cell tumor is the most common tumor which is seen in this particular site. And how it is present? It is expansile. Expansile means, so if you take the cortex, so this is the cortex, right? So here if you measure this cortex, so if you see this area, so this area you can see this lesion has extended beyond the cortex, right? So usually what happens is whenever there is a lesion like this, it is only inside the cortex. But here when you measure it with the below or above cortex, the lesion appears to be wider. So that is why it is expansile. What do you mean by eccentric? Eccentric is towards end, towards particular end. So it is not exactly in the center. It is somewhere in the end towards a side, so this side. So you can see it is somewhere towards this side, and it is in the epiphysis, usually in the subchondral area. You can see it is already, it is like abutting the joint. That means it is almost near to the joint, but it will never cross the joint. It is very, very obedient tumor, will never cross the joint, but you can see there is a lot of lysis which is happening. So on the x-ray, what you see, so whenever you take the x-ray and whenever you see a giant cell tumor, you can see this is a lytic lesion which is eccentric and expansile in the epiphysis with a soap bubble appearance, which is very, very important, which you have to note on the x-ray. And now coming to the biopsy. So coming to the biopsy here, once the x-ray diagnosis is made, we have to confirm the diagnosis by sending it to the biopsy, that the tissue diagnosis, that the HPE. On the HPE, what you see is the giant cell tumor appearance. So you see a giant cell tumor, multiple giant cells which I've seen. So multiple giant cells which are nothing but the fusion of the mononuclear cells. So they will see giant cells with number of the mononuclear cells on the histopathological examination. So that is the biopsy. And now the treatment. So the treatment is usually surgical treatment. What is the surgical treatment which we are going to do for giant cell tumor? We are going to do the curettage. So curettage, that is also an extended curettage. So you're going to do the treatment is extended curettage. So if you see all the E's, so it is in the epiphysis, eccentric, expansile, right? And then we are going to treat it with extended curettage. And one more E is your eggshell crackling sound. So usually what they say is on the examination, when you are going to touch the patient, this is usually felt when it is big. When the big tumors, you can see the eggshell crackling sound or eggshell crackling like feeling on the palpation, right? But usually whenever it is small, you don't feel much. So these are the various E's which are connected with your giant cell tumor. So what do you mean by extended curettage? So similarly, again, you see this is a cavity again, which is filled with giant cell tumor. So now we are going to remove this tumor. How we are going to remove this tumor? So there is a lot of tumor. So here what you do is you go to the cavity and then you use the curette. So this is the curette, something like a spoon like thing. So something like a spoon. So you entirely curate, so completely you remove the tumor. So now you are left with this cavity, right? So if you leave the cavity, what will happen is there is a recurrence. So always there is a recurrence. So now what you do, you use this adjuvant. So what are those adjuvants? You can either use a liquid nitrogen or you can use a bone cement, right? So a liquid nitrogen or a bone cement which you put in this cavity, so that the cavity, there is no space for the tumor cells, and because of the bone cement produces heat, the cells which have been remnant or attached to the cavity will also die. So this adjuvant, whenever used along with the curettage, this is called as an extended curettage. So this is called an extended curettage, right? So what is a curettage? Simply removing the tumor from the cavity is curettage, which we use for simple bone cyst. But when we do extended, that means we are using a liquid or we are using something in adjuvant, in addition to the curating. So this is the liquid nitrogen and the bone cement, which is called as an extended curettage. So extended curettage. And sometimes if the tumor is very, very big, you can also go for the excision of the tumor. So this excision is not as simple as we think, because of its site. So here what is happening, the epiphysis is getting involved, and these epiphyses, they form joints, right? So you can't remove the joints as like. So now they have come up with a procedure which is called as the turnoplasty. This is called as the turnoplasty because the epiphysis is involved, and if you want to remove the epiphysis, the joint gets involved, right? So we don't want to lose the joint. So they have come with a procedure which is called as a turnoplasty, and usually it is done whenever there is an involvement of the lower end of the femur. So lower end of the femur or the lower end of the tibia. So these form the knee joint. So here we do turnoplasty. But whenever it is the upper upper end of fibula, if it is an upper end of fibula, or if it is an upper end of ulna where there is no joint, so there is no involvement of the joint, simply you can go for the excision. So simply you can go for the excision. But if it is femur or the tibia, what you do is take up a tibia, or you take, so turnoplasty, what actually it means is, so this is your fibula, right? So they have cut open this fibula and they turned and use it for the femur, right? So upper end of the fibula is taken and they have used it for the femur. So that is turnoplasty technique, which is used for reconstruction of the joint. But nowadays what we are doing is, we are doing a simple TKR, that is your total knee replacement. So we are going for arthroplasty instead of the excision and turnoplasty. This is with the long stems, right? So here we put the prosthesis. So usually the prosthesis only up the knee joint, but for the osteosarcoma, what we do, we use the stems. So these are the extended rods which are attached to the prosthesis. So this rod will act as the your turnoplasty technique. So this rod will hold the medulla, and the tumor is completely removed. You put this rod and put the prosthesis. So the TCAD is now used for treatment of your giant cells tumor, right? But it is, if it is very, very large tumor, if it is very large tumor. So next coming with the Ewing's sarcoma. So coming to the Ewing's sarcoma. So here what you have to remember is, this is a tumor of, again, first decade. So here the age is up to 10 years, right? So it is a tumor again of the first years, that is the below 10 years of age. And the most interesting thing is, the origin of the Ewing sarcoma is from the neuroectodermal, primitive neuroectodermal tumor, that is the PNET, right? And here one more important thing what you have to remember is the site. The site, usually it occurs in the femur predilection, and in the femur the most common site affected is the diaphysis. So going back to the giant cell tumor, it is mainly the metaphysis which is involved. So metaphysis is the one which is very much involved. Sorry, the epiphysis is the one which is very much involved. Here in the Ewing sarcoma, it is the diaphysis. Ewing sarcoma, this is the diaphysis, right? And here in the Ewing sarcoma, it is usually the tumor which is present in the medulla, and here there is a typical periosteal reaction which we see in the Ewing sarcoma. This periosteal reaction is in the layers of new bone formation. This layers of new bone formation is called as the, what this is called? This is called as the onion peel appearance. So you can see there is an onion peel appearance on the X-ray, right? So this new layers of newborn it is formed. This is called the onion peel appearance. Okay. And then what is another interesting feature is, sometimes this is present as air on end appearance. So this is present as air on end appearance. So this is the periosteal reaction. The X-ray what we see is the onion peel appearance. So if this is the tumor, now you see there are multiple layers of newborn formation. This is seen as your onion peel appearance. So this is very classic for your Ewing's sarcoma, and I have told you that this occurs mainly in the diaphysis, right? So what is the important thing you will remember? First, you have to remember that it is the tumor of the first decade. It is the tumor origin is PNET, site is diaphysis. The most important thing is the periosteal reaction, right? And now what is another interesting feature is the symptoms and signs. So the patient presents with pain and he presents with fever, and when you do the lab testing there is a raised ESR and raised WBC also. What do you think of this symptom? Like, what do you think of this picture? So there is a patient who has come almost about 6 to 7 years. He come with pain, especially in the thigh region. So I've told you the femur is involved, right? So he'll have pain in the thigh, he will have fever, maybe low grade fever with raised ESRs and WBC. Don't you think that you will land up in infection? Yes, that is the beauty of reading. That is the beauty of the having the knowledge. So always beware that in ortho, don't just jump into the conclusions of, it is infective, it is tumorous. Always test the biopsy. So the biopsy, the final diagnosis is the pathology, where you have to send it for culture and sensitivity and biopsy, right? So whenever the culture and sensitivity is positive, that means it is infection. If it is tumor cells are detected, then it is a tumor, right? So here in Ewing sarcoma, especially, the patient have these particular symptoms like pain, fever, ESR, WBC, and usually the males are more commonly affected. And you also have to remember there is a translocation of T11-2022. So this is the translocation which you have to remember, that is T11-2022 associated with your Ewing's sarcoma. Okay, and now when you send for biopsy, what you see? So sending on biopsy, what you see? So biopsy is, you see that these are round cells, and these round cells are blue in color. So blue color round cells you see all over. So blue color round cells, mononuclear blue color round cells, completely in the blue. So this is on the Zoom, I am not able to show you properly. So this is the blue color what I was telling about. So complete sheets of blue cells, round blue color cells. Okay, so that is about the biopsy. Okay, and then we have discussed about the symptoms, and now you take the x-ray. On x-ray we have already discussed that it shows on the diaphysis, and the periosteal reaction is nothing but your hair onion peel appearance or hair on an appearance, right? So then the biopsy we send, and how do you treat it? So management is, again, you have to remember that this is one of the most notorious tumor, but it is very, very sensitive to radiotherapy. We don't use radiotherapy because, again, radiotherapy induced osteosarcoma is one of the complications. So usually it melts on radiation, but the radiotherapy is not very much useful for it. So we go for surgical excision, right? So we go for surgery, and then we go for chemotherapy. So chemotherapy, we are using multiple drugs such as doxorubicin, ifosfamide, and vincristine, etoposide. These are all the drugs which can be used for chemotherapy. And after chemotherapy also, depending upon the size, we go for adjuvant or neoadjuvant chemotherapy. Okay, so this is about the Ewing sarcoma, where the treatment is radiotherapy and chemotherapy. But the most important things what you have to remember is the diaphysis, the onion peel appearance, and then it presents as the infection. So you are going to depend on the biopsy, and management is again radiotherapy. It melts like snow, and there is surgery and chemotherapy. Chemotherapy, if you want to write, you can write the vincristine, ifosfamide, etoposide, doxorubicin. So these are the drugs which are being used, right? And what are the complications? So again, the patient may land up in infection of the tumor. So metastasis, chemotherapy and radiotherapy side effects. Right, so these are all the complications of the Ewing's sarcoma. Okay, then we are going towards osteosarcoma. So here, very, very important, osteosarcoma. So here, this is the most common malignant tumor. So this is the most common malignant tumor we see of bone, right? And what is the most important thing of osteosarcoma? So here, osteosarcoma is nothing but a tumor of osteoid. That means this is a bone forming tumor. So bone is formed. It is a tumor of osteoblast. Okay, tumor of osteoblast. So on the biopsy, what you see is seams of osteoid you see on biopsy. That is how you diagnose it, right? So the first thing what you have to remember is the osteosarcoma is most common malignant tumor. Again, it occurs in the second decade right? It occurs in the second decade, that is, occurs in the first decade, that means 10 to 20 years of age. 10 to 20 years of age. So usually it occurs in the 10 to 20 years of age. And most interesting thing is it is seen in the metaphysis. So most interesting is it is seen in the metaphysis, similarly like the infection. So 10 to 20 years, metaphysis, bone forming tumor. So whenever the bone is formed on the x-ray, you see two interesting things. One is the bone is formed along the capillaries, which is called as the sunburst appearance. So this bone which is present is formed along the capillaries. And the second one is the Codman's triangle. So there is an elevation of the periosteum which is seen as the Codman's triangle. So these are the two interesting features on the X-ray which are very, very specific for your osteosarcoma, right? And then osteosarcoma is usually associated with the metastasis, right? So here the most common is lung mets. So you have to always take a chest X-ray to plan the treatment. So lung metastasis is very, very common in the osteosarcoma. And then the most common site is again the knee. So usually the knee joint is the one which is most commonly affected, and now the patient presents with the pain, swelling, right? So they present with pain and swelling, right? And once they present with pain and swelling and you take a x-ray, you see this is the osteosarcoma, where you see a lot of bone formation. Okay, and then you can see this bone is along the capillaries, which is called as the sunburst appearance. So you can see this is called the sunburst appearance. This is the sunburst appearance. And here a small elevation of the periosteum. So the elevation of the periosteum, this is called as the Codman's triangle. So here this is called as the Codman's triangle. Okay, so these are the most important features. And biopsy, I have already told you that you see a lot of osteoblast and a lot of bone formation, that seams of osteoid which are seen on the biopsy, right? And then what do you do? The osteosarcoma, the types of osteosarcoma. So there are types of osteosarcoma. In the types of osteosarcoma, you have osteoblastic, chondroblastic, fibroblastic, and telangiectatic. So this is one of the most aggressive tumor, right? This is based upon the histopathology. So osteoblastic, chondroblastic, fibroblastic, and telangiectatic. And then we also have two more important, that is paraosteal osteosarcoma and periosteal osteosarcoma. So these are again variants, like two different types of osteosarcomas. No need to remember much about it. Only remember the most aggressive one is telangiectatic osteocarcinoma. Okay. So here these are the types of osteosarcoma. These are the types of the osteosarcoma which we usually encounter, right? And then coming to the management. So coming to the management here, initially whenever we are being treated with osteosarcoma, what happened, there was amputation which is being advised. But now with the advancement of the chemotherapy, we are being dealing with the osteosarcomas without amputation. So you have the neoadjuvant chemotherapy plus surgery, that is removal of the tumor, plus adjuvant chemotherapy. So this is the treatment of your osteosarcoma. And the chemotherapy what we use is the doxorubicin and if ifosfamide, and then we have your methotrexate, and then the cisplatin. So these are the chemotherapeutic drugs which we use for treatment of your osteosarcoma. So here what we do, first we give a dose of neoadjuvant chemotherapy which will debulk the size, and then we go for surgery, remove the tumor, and this removal of the tumor is compensated again with the prosthesis, as we have discussed for giant cell tumor. Whenever the large tumor is present, so you can go for arthroplasty. Here similarly we go for arthroplasty, removal of complete tumor, and then we go for adjuvant chemotherapy if these margins are still positive. So once you remove all the tumor, you send it for the lab diagnosis, and then if this are still positive, the margins are not very clear, then again you go for a adjuvant chemotherapy. So that is how you treat the cases of osteosarcoma. Right, so this is about the osteosarcoma, and now we have finished the giant cell tumor, and then the Ewing's and the osteosarcoma from the oncology, and chronic osteomyelitis, acute and TB spine from the infections. Hope this helps for you in your upcoming Farre exam. So you're going to download the Meded app, and you're going to see a lot of clinical corner questions and the Farre itself for all other subjects. So thank you so much for the patient listening, and if you have any doubts, you can always come back. And this is our Instagram handle, Dr. Alekhya Ortho and PW Meded. So hope to see you